Alright, welcome back to class everyone. Trevor Mashak here. Today's lecture is part one of a two-lecture series, and we're going to be discussing OB and GYN. So OB stands for obstetrics, and GYN stands for gynecology. Obstetrics is the study of pregnancy from the start of conception all the way through labor. Gynecology is the study of just the female reproductive system. Now, a bit of a disclaimer, this is kind of a misnomer because really we're going to be focusing on the obstetric side of things and not so much the gynecology side. The reason for this is that realistically, when it comes to emergencies, obstetric emergencies kind of take the cake for having the higher mortality rate and the higher morbidity, while gynecology emergencies certainly can be debilitating and they can certainly end a trip that you're taking, be it a recreational trip or a professional trip. We are going to focus on the OB side of things because that's when things can really go south. That's when we start seeing problems with mother and potentially death occurring, and then also fetal mortality as well. So this is absolutely something that you might run into in the wilderness setting. Women that are pregnant certainly are active in the recreational side of things. So over here we have a pregnant woman running, and this is actually Amber Miller, and this is a picture of her running a marathon. And believe it or not, a couple hours after she finished the Chicago Marathon, she actually went into labor and delivered her baby. So we actually do see a lot of pregnant women getting outside and being active in various recreational sports. Here we have a pregnant woman climbing. You can see that she's wearing a special harness, so there are special harnesses made for pregnant women. Over here we have a pregnant woman. It looks like she's cross-country skiing, so absolutely something that you might see in your recreational or your professional lives. So first we're going to just talk a little bit about normal pregnancy. This is by no means a comprehensive review of pregnancy and the entire process, but there are a couple key processes that I want to mention, and they'll come up later when we talk about various complications. So here we have a diagram of an ovary with the fallopian tube, and so it should be recognized that fertilization of the zygote, which is the scientific name for the egg, occurs in the fallopian tube most of the time. After the egg is fertilized, it then takes about 4 days, anywhere from 4 to 8 days, to move down into the uterus, where it implants on the endometrium. The endometrium is the lining of the uterus, and it provides nutrients to the fertilized egg. Fetal development then takes place within the uterus over the next 9 months or so, depending on how long the gestation actually lasts. We break up pregnancies into 3 trimesters. So the first trimester is from conception to 12 weeks of pregnancy. The second trimester we see from 13 to 24 weeks of pregnancy, and then the third trimester is 25 weeks all the way until the mother goes into labor and delivers the baby. While the baby or the fetus is in the uterus, he or she receives nutrients from the placenta. So the placenta is this organ that's implanted along the uterus wall, and essentially what we see here is basically there's kind of a thin interface between the fetal circulation and the maternal circulation. So maternal being the mother's circulation, fetal obviously being the baby's circulation. So the blood doesn't actually mix. The circulations are completely separate. But at the placenta, we have this thin interface similar to what we have in our lungs and what we have at our tissues, but we basically have fetal capillaries that are right up next to the maternal blood. And so that's where oxygen is going to diffuse from the maternal circulation into the fetal circulation. And then we also have carbon dioxide and other wastes diffusing out of the fetal circulation and into the maternal circulation. So the placenta is absolutely fundamental for the fetal development. It's how the growing baby receives all its nutrients and disposes of all of its wastes. Generally speaking, like I said, the fetal blood never mixes with the maternal blood. We can actually see a lot of complications from that. So basically, the mother's blood can be a different blood type than the fetus's blood. This shouldn't be very surprising to you if any of you have kids. You might know that your son or your daughter has a different blood type than you. And so essentially what can happen is if the blood mixes, you can actually have essentially a transfusion reaction. So the mother can have almost like an allergic or anaphylactic reaction to the blood. It's a little above what you guys need to know. Just realize that the blood, the circulation, commonly does not come into contact with each other. During pregnancy, we observe a lot of physiological changes on the maternal side. And a lot of these physiological changes are basically there to accommodate the developing fetus. So we're just going to go through a couple of them. Some of them are important, some of them are just worth being aware of. But cardiovascular-wise, we see an increased volume in circulating blood. So the mother will increase the amount of blood that she is circulating. Her heart, she'll have an increased cardiac output and an increase in the resting heart rate. And this is basically to facilitate more oxygen delivery to the growing fetus. If you think about it, now mother is delivering oxygen not only to her own tissues, but to the fetus. So she's really breathing and circulating blood for two. And so that's why we have this increased heart rate, this increased cardiac output. We see a decrease in systemic vascular resistance. So systemic vascular resistance is basically what we measure when we're measuring blood pressure. So the mother will typically have a decrease in her blood pressure, and it's not super significant. We're talking 5 to 10 millimeters per mercury systolic. It should be observed, I guess we'll kind of skip down here to the heme. So she actually has an increased plasma volume and an increased number in red blood cells, but the plasma volume actually outweighs the increase in red blood cells. So if you can imagine, while she has an increase in blood volume, her blood is a little bit more dilute. And this can be significant because if she has some kind of trauma and she loses blood, well, her blood isn't as concentrated as it used to be, so she could have very much more significant ramifications if she's experiencing some blood loss. We also observe some problems in coagulating blood, so they can certainly have problems with forming blood clots. Let's jump back up here. So respiratory, we see an increase in the tidal volume, so that's an overall increase in how much she breathes in during one breath. And we see a decreased functional residual capacity. This last one, don't worry about looking up what that means, but essentially as the uterus grows, as the fetus grows, it puts more pressure on the abdominal organs. This pushes up into the diaphragm, meaning that she can't inhale as deeply. So there's this decrease in functional residual capacity. Again, don't worry about that term too much. The big take home here is that as she has this increase in her abdominal cavity size due to the growing fetus and the enlarging of the uterus, if you have a patient that's supine, if say you have her placed in a litter or placed on a backboard, those stomach contents are going to put more pressure on her diaphragm than would be in a normal person, or sorry, I shouldn't say normal person, but a non-pregnant person. So basically what that means is she's going to have a harder time breathing because the diaphragm has more to push against. So that's definitely something you should keep in mind when managing a pregnant patient, especially if she's in the later stages of pregnancy. So some other changes that we see, increased in kidney size, renal blood flow, and glomerular filtration rate. So there's going to be increased urination during pregnancy. And this is basically to keep up with that increase in waste that's being developed. Again, all the mother's tissues are developing wastes as per usual, but we also now have the fetus that's also developing waste during development. We already talked about the changes in the blood. Gynecological, as you can imagine, as the fetus starts to develop, as the fetus starts to grow, the uterus must grow as well. So we see the uterus becoming larger and weighing more and taking up more volume within the abdominal cavity. We also have increased uterine blood flow, so obviously we're going to want to move more blood to the uterus than we would if we weren't pregnant, because now we have to supply blood to the uterus and therefore to the fetus. So now that we've briefly covered the normal aspects of pregnancy, we're going to jump into the complications that can occur during a pregnancy. So the first thing that we're going to talk about is ectopic pregnancy. This is absolutely something that you need to be aware of because it's fairly common. It occurs in about 1 to 2% of all pregnancies, and it can absolutely be life-threatening. So let's define what an ectopic pregnancy is. So an ectopic pregnancy is basically when the egg implants somewhere other than the uterus. So again, we mentioned earlier that the egg typically will implant on the wall of the uterus. Well, if that egg implants anywhere else, then it's termed an ectopic pregnancy. Most commonly what we'll see is the egg will actually implant within the fallopian tube. So remember, that's where fertilization occurs. Well, if the egg does not travel down to the uterus as it normally would, and it implants within the fallopian tube, well, that's when we start to see problems. As you can imagine, the fallopian tube is a rather small structure. And so if we have an egg implant within the fallopian tube and start to develop, well, we're going to run into some problems. The fallopian tube does not grow and cannot facilitate a developing fetus as the uterus can. And so what can actually happen is as that fetus starts to grow, usually around 8 weeks to 12 weeks, that fetus actually becomes big enough that it can rupture the fallopian tube. This is a big problem because we have some arteries that run along the fallopian tube, and so if we have a rupture of the fallopian tube, we ultimately have an arterial bleed going on as well, and the mother can absolutely go into hypovolemic shock. She can absolutely have internal bleeding from this complication and ultimately die. It should be it's worth noting that an ectopic pregnancy is not a viable pregnancy, and so mothers or women will commonly be concerned when you're saying that this might be an ectopic pregnancy. Well, they're concerned that they're going to lose this baby, but it's worth noting that this cannot be a viable baby. The mother will not deliver this baby because the baby just does not have anywhere to develop. It cannot develop in the fallopian tube or elsewhere. Kind of jumping back up to this top bullet point, so ectopic pregnancy is the leading cause of maternal death in the first trimester of pregnancy, and it is the second leading cause of maternal mortality overall. So again, a very common, or a rather common complication, and it can absolutely be life-threatening. So you need to have this on your radar when dealing with these patients. So signs and symptoms of an ectopic pregnancy. Commonly, the female will be experiencing lower abdominal pain. It can be either on the right side or the left side, or it can actually be on both sides, depending on the circumstance. We can see some radiation of the pain, so if there is internal bleeding and the blood has moved all the way up to the diaphragm, she might be experiencing some referred pain to her shoulder. So if a female is complaining of lower abdominal pain with radiation to the shoulder, that should absolutely be concerning. Absence of menses, so she hasn't been having a menstrual cycle. Well, believe it or not, this is common in ectopic pregnancy, but it's not 100%. I think it's about 80% of ectopic pregnancies will have an absence of menses, while there's another 20% of patients that will continue to have their menstrual cycle as normal. And again, this all comes back to that egg being implanted outside of the uterus. The patient may have some vaginal bleeding. Typically, this is not profuse, so it might be described as spotting, but it will not usually be a menstrual flow. It will be described as bleeding, and she'll say that it's not her normal menstrual period. Ultimately, the ones that we're really concerned about, the signs and symptoms that we're really concerned about, are the signs and symptoms of shock. So I mentioned before, and I'll mention again, that if we have an ectopic pregnancy within the fallopian tube, and it causes that rupture, and it causes that arterial bleed, she can go into hypovolemic shock. And so if that happens, we will absolutely see these signs and symptoms of shock. By this point in the class, you should know these by heart, but I'll run through them real quick just as a reminder. So we'll see an increase in heart rate. We may see a drop in blood pressure depending on how much bleeding has occurred, depending on if she's able to compensate. We'll typically see an increase in the respiratory rate, and then we will also see that cool, pale, diaphoretic skin. anytime we say cool, pale, diaphoretic skin, you should automatically think signs and symptoms of shock. This last point is super important. So ectopic pregnancy should be considered in all women of childbearing age who present with abdominal or pelvic complaints or with unexplained signs or symptoms of shock or hypovolemia. So if you have a female patient and she's complaining of abdominal pain, you absolutely should have ectopic pregnancy at the top of your list. You should absolutely be worried that she might be experiencing an ectopic pregnancy. Even if she says that she is not sexually active, even if she tells you that there's no possibility that she's pregnant, well, this is kind of a touchy subject. A lot of people are not fully honest when they're discussing this topic. And so even if she says that she can't be pregnant, she wasn't sexually active, then you should absolutely still have this on your list of possibilities. The woman, the female may believe that she could not be experiencing ectopic pregnancy because she's been using some form of contraceptive, be it a pill or condoms or whatever it is. But realize that all forms of contraception are not 100%. So even if they have been using condoms regularly, realize that pregnancy is still a possibility, and therefore ectopic pregnancy is also still a possibility. Over here on this picture, obviously I don't expect you to be able to read an ultrasound, but basically what we're seeing here, this big black stripe right here, is representing internal bleeding. So again, just to really drive the nail into the coffin, you can absolutely have hypovolemia and have death occur due to internal bleeding from an ectopic pregnancy. The next condition that we'll talk about is called hyperemesis gravidarum. So it shouldn't be surprising to you that during the normal course of a pregnancy, the female will experience commonly an increase in nausea and frequent vomiting. Well, hyperemesis gravidarum is not just your typical morning sickness. This is excessive nausea and vomiting during pregnancy. This is commonly a debilitating condition. So usually a female that's experiencing hyperemesis gravidarum is usually bedridden. She's staying home and commonly will need to go to the hospital because she's just so so complicated by this condition. But absolutely, I could see this being a situation where someone might not listen to their body. They might be out in the wilderness camping, backpacking, hiking, whatever it is, and experiencing this and having complications from it. So it can absolutely lead to significant dehydration. This shouldn't be surprising. Anytime we have a patient with uncontrolled vomiting, we are concerned about dehydration or hypovolemia. We're also concerned about some electrolyte abnormalities. So as someone vomits a lot, they lose a lot of electrolytes. They also can go into a state of alkalosis, so the opposite of acidosis. They can absolutely be experiencing hypoglycemia. So if you can imagine someone that's vomiting excessively, they're not being able to hold down their food, they're not getting the nutrients, and so their blood sugar can absolutely be low. If they experience a sustained period of hypoglycemia, then their glycogen stores, so the extra sugar that we store in our livers and in our muscles, will become depleted. So this is something that, if it happened in the wilderness setting, then we're concerned that she's going to have an increased incidence of, say, heat exhaustion or exposure, because as we become dehydrated, we don't really tolerate the elements as well. Also, if someone's been hiking a lot, then they have that compounding onto this excessive nausea, vomiting, and so we can have very, very significant dehydration if a female is having hyperemesis gravidarum in a wilderness setting. Supine hypotensive syndrome. So this is something that you absolutely need to be aware of. So essentially what's going on here is when the mother is placed in a supine position, the gravid uterus, so the grown uterus, can compress the inferior vena cava. So remember that inferior vena cava is this very large blood vessel that brings blood back to our heart. And so if we have the uterus, a very large uterus, say in the second or third trimester, pushing down on the inferior vena cava, well, we have decreased blood return to the heart, and therefore we have a decreased cardiac output. And so ultimately what happens is the mother will become hypotensive, so she will have a low blood pressure because of this decrease in return of blood to the heart. If this goes without fixing, if the mother is placed in a supine position for an extended period of time, well, if she has a decreased cardiac output, then ultimately the fetus is going to have a decrease in perfusion, and this can absolutely lead to fetal death. The reason why this is so important for us to understand is because if you have a pregnant woman that, say, gets injured in the Sandias, and you're doing a litter carryout, well, if you place her in a supine position for 3 hours during a litter carryout, this could absolutely happen. This could absolutely be something that we induce, and this is something that we want to avoid. So anytime that you have a female patient and you need to have her in a supine position, be it she's on a backboard, she's in a evac mat, or she's in a litter, what we need to do is we need to have her placed in a left lateral recumbent position. So what does that mean? That means that we need to have her body tilted slightly to the left. And we'll typically wedge something under the right side of her body so that we get that angle. We want to have about a 30-degree angle. And what this does is it allows the uterus to slide off of the vena cava and it allows blood to return to the heart effectively. Moving right along, we have preeclampsia and eclampsia. So preeclampsia is a condition that typically occurs in women over 20 weeks of gestation. It can absolutely occur before that, but most commonly we'll see it after 20 weeks of gestation, so about halfway through the pregnancy. We should suspect preeclampsia anytime a pregnant woman has high blood pressure, so anytime her systolic blood pressure is greater than 140 millimeters of mercury, or her diastolic pressure is greater than 90 millimeters of mercury. Similarly, we should suspect it anytime we see these signs and symptoms in a pregnant woman, so headache, blurred vision are two very common symptoms that we see with preeclampsia. And then we also will see edema or swelling in the extremities, so swelling in the hands, swelling in the feet, etc. We're not entirely sure why preeclampsia occurs, but we do know that it can be very life-threatening. It can cause fetal complications during development, and ultimately what we're really worried about is that preeclampsia will then develop into eclampsia. And so eclampsia is basically the same as preeclampsia. We see the same symptoms. We see high blood pressure, we see blurred vision, we see a headache, we might see that swelling in the extremities, but then we also see seizures. And so this is the big concern with preeclampsia, is that it's going to develop into eclampsia, which is defined by the presence of seizures. Anytime we have a pregnant patient experiencing seizures, we are concerned that she is in eclampsia. So eclampsia has a very high mortality rate for both the mother and the fetus, and so we need to be very concerned about this condition. These seizures are not like your typical epileptic seizures. They typically go uncontrolled, so they are not self-limiting as a normal epileptic person's seizures would be. But this is most commonly a grand mal seizure, and again, these seizures can go for extended periods of time. For both preeclampsia and eclampsia, we really want to have that high index of suspicion. We want to request advanced life support early on, and we need to do immediate evacuation. These patients need to be in the hospital, they need to be monitored. Typically they'll be on medication drips to try to control their blood pressure and try to prevent these seizures. And eventually, if the mother does start having seizures, then she really needs to have an emergency C-section. So this is absolutely an emergent condition that we need to be aware of. So now we're starting to move into the conditions that take place more during the second and more importantly the third trimester. The first one that we'll talk about is placenta previa. So placenta previa is basically when the placenta is implanted in the inferior aspect of the uterus and ultimately is covering part of the cervical opening. Again, the cervix is that passage between the uterus and the vagina, and so in this case the uterus is sitting either partially or completely over the cervical opening. The problem with placenta previa is that we see that the baby is not receiving as much circulation, is not receiving as much blood supply from the mother, because this area by the cervix is not going to oxygenate the placenta. We also see that there can be the presence of bleeding, and this bleeding can go to the point that it develops into shock for the mother. We also can see the placenta rupture from fetal pressure, and ultimately, if the patient has placenta previa, then she's going to need to have a C-section. It doesn't necessarily need to be an emergency section. Commonly, these patients will just be monitored and have a C-section scheduled when the baby is term, but it can absolutely be an emergent situation if there's an increase in bleeding or if there's fetal distress observed by the emergency department. Signs and symptoms of placenta previa. Classically, it's described as painless, bright red vaginal bleeding occurring in the second or third trimester. This painless aspect isn't 100%. Sometimes this can be painful bleeding, especially if there's also a little bit of placenta abruption going on as well. But most concerning, we're looking for the signs and symptoms of shock. And so you're seeing that this is probably a reoccurring theme with all these OB emergencies, but we are most concerned about the development of shock in the pregnant woman. Treatment, we're going to, of course, go through our shock management. So we're assessing the ABCs. We're providing high flow oxygen if we believe that she's in hypovolemic shock. We're requesting advanced life support for fluid resuscitation, and we're doing immediate evacuation to an emergency facility, specifically one that has on-call OB-GYN. The next condition that we'll talk about is placental abruption. So this is basically when the placenta is peeled away from the uterine wall. This can happen partially. We can have a partial placental abruption where basically just part of the placenta pulls away from the uterine wall, or we can have complete detachment. And again, this happens in women that are over 20 weeks of gestation, so typically second, third trimester complication. With this, we will have abdominal pain associated with the vaginal bleeding. The vaginal bleeding is commonly described as a dark red blood, as opposed to that bright red blood that we have with placenta previa. So placental abruption, I'll just repeat that, dark red, painful vaginal bleeding. This can absolutely be profuse bleeding. The mother is at risk for going into hypovolemic shock. I would say she's more at risk for going into hypovolemic shock with this condition than with the placenta previa. Recognize that vaginal bleeding does not happen in 100% of these cases. So about 20% of placental abruptions are what are called concealed abruptions. And so basically the bleeding is contained by the placenta, so it's happening on the center aspect of the placenta. Now, just because it's contained by the placenta does not mean that she's not going to go into hypovolemic shock. She can absolutely bleed out into the uterus and have it contained within the uterus, so we don't see that vaginal bleeding, but she can go into shock. So just because there's not vaginal bleeding does not mean that you should not be concerned. She's having severe abdominal pain. We really need to be concerned that this is a possibility. Again, we'll see those signs and symptoms of shock. I'm not going to repeat those. You should know those by now. The next complication that we'll talk about is uterine rupture. So essentially what happens is we have, as you can imagine, as the name implies, a rupture of the uterine wall. We have the uterine contents spilling out into the abdominal cavity. This is most common in women that have had a previous cesarean section. So if she had a C-section in her last pregnancy, she has that scar tissue, well, that could absolutely be a weak point in the uterus for this, this current pregnancy. And so typically this will happen during a traumatic event, or it can happen just during active labor. So as the uterus starts to contract, it starts to push the fetus against that weakened area of the uterus where she previously had the C-section, and then we have that uterine rupture. This is a very life-threatening event. Commonly, the fetus will not survive a uterine rupture, and mother can also not survive. So this is certainly an indication for immediate surgery. So just to repeat that, high mortality rate for both the mother and the fetus. The signs and symptoms that we're looking for here, well, we have severe abdominal pain. We may have vaginal bleeding as well. This ripping and tearing sensation at the event of either during labor or during the traumatic event, whatever it was, she might describe this tearing sensation. And then commonly after she has a uterine rupture, she's going to have contractions. And so the uterus is going to be irritated, she's going to have uncontrolled contractions, and they commonly aren't our normal contractions. These are not the 2 to 3 minute contractions or the contractions happening every 2 minutes. These are just consistent contractions. Again, we're very worried about signs and symptoms of shock. You may, if you palpate the abdomen, you may actually be able to feel the fetus outside of the uterus. In that case, the fetus is most likely dead, and mother also is in a severe condition. She is at high likelihood for dying as well. Real briefly, we're going to talk about trauma in pregnancy. So the most common causes of traumatic injury in pregnant patients, we have motor vehicle accidents. Well, that's just because motor vehicle accidents are fairly common. And then also we have falls, and so it shouldn't be very surprising that as she starts to have this growing uterus and fetus, well, her center of gravity is going up, and so we have an increased incidence of falls. Typically, we're talking about ground level falls, and so these aren't necessarily as severe. However, I want to mention that every pregnant patient that experiences a traumatic event, even if it's, maybe you consider it a minor mechanism, she needs to be evaluated in the emergency room. And the reason is, if she starts to go into shock, you might not see it. So they start to compensate pretty well early on, but if the mother is compensating, realize that what's happening internally is the blood, the circulation that's normally going to the fetus is being shunted away from the fetus in order to keep the mother alive. And so with traumatic events, even if the mother looks okay, we can have fetal distress, we can have increased fetal mortality, and we might not suspect that there's a lot of trauma. She might not have any external signs of trauma, but really she needs to be evaluated in an emergency room. Placenta abruption can absolutely occur after a traumatic event. So let's say she's in a low-speed motor vehicle accident. Let's say the airbags didn't even deploy. Well, as she comes to that deceleration, as she experiences that deceleration, the placenta can pull off the uterus, the uterine wall, and we can have a placenta previa. So, we really need to have a high index of suspicion. We need to recommend that these patients be evaluated immediately. Again, I already mentioned it earlier, but any pregnant patient that we have, if we're transporting her, we need to place her in a left lateral recumbent position. So we see that nicely on this diagram. The patient is on a backboard. It looks like she's on a gurney, but we have towels placed under the backboard here to allow her to be on her side and therefore allow adequate blood return to her heart. This is a very important point to keep in mind. Something else worth mentioning about the traumatic patient, the traumatic pregnant patient. So during the course of pregnancy, there's a hormone secreted that actually loosens up all the ligaments in the body. And the point of this is basically there's this symphysis pubis, this connection of the pubic bone that's connected with a ligament. And this hormone secreted to kind of loosen up that joint. That allows the pelvis to open up and facilitate childbirth. Well, this hormone works on all the ligaments in the body, and so the ligaments in her shoulder, in her knees, in her hips, and all of her joints are going to be loosened. And so pregnant patients, when they experience traumas, traumatic events, or even just minor traumatic events such as a ground level fall, we have an increased incidence of dislocated joints and so forth. And so that's absolutely something that you might come across. A pregnant woman who's walking along, maybe experiences just a trip and a fall and then has a dislocated hip, that can absolutely occur. So this concludes our lecture on obstetric emergencies. Up next in the upcoming lecture, we will be discussing emergency childbirth and how to deliver a baby. But hopefully this gives you an idea of emergencies that can occur during pregnancy and gives you the proper information on how to recognize these emergencies. If you have any questions, as always, please post them in the forum, and I hope you enjoyed the lecture.